Thank you for kind introduction. My topic is CT guide intervention in abdominal disease. In general, the benefits of CT guide interventions include it can access to deep lesions and is minimally invasive with low complication rates and is feasible in patients with comorbidities. In clinical practice, CT-guided biopsy could guide a treatment plan, and CT guide drainage is effective in infection control. And this is a common case. The female has had a pelvic abscess, and it is easy to find a safe path, one or more safe paths, and the procedure would be simple and straightforward. So we had the patient under prone position, and the needle puncture and the genitourinary insertion were done smoothly. But sometimes challenging cases come up. The case number 1 is a male with a pancreatic lesion at his pancreatic enzyme process. They denied US guided biopsy, so CT guided biopsy is suggested. And at the first glance, there is no safe path. The procedure would not be straightforward. And the case number 2 has intra-abdominal abscess in her lower abdomen. It seems not straightforward too. For such central abdominal lesions, to find a safe path is the major issue. And the lesion more often showed intervening structures that make the access difficult. And the intervening structures could be critical, so the risk of complications is increased. And for upper abdominal lesions, respiratory motion and the parietal pleura may make the access more difficult. Since a straightforward path is rare in the patients with central abdominal lesions, we developed a fat traversing technique to find any safe one. The core concept of this technique is needle path between visceral organs. We also call it detour path. And the path is the trajectory of needle tip, not the shape of needle body. For example, the DR1 tract. When the needle tip run beside the gallbladder and the stomach, we change the direction of needle tip. And the needle body would push the stomach away, so the stomach won't be punctured. Then you can puncture the target lesion. And you can find many detour paths on this actual image, but actually detour paths could be in caudocranial direction when it is needed. Now let's look back at the case number 1. The pancreatic lesion was surrounded by duodenum, pancreatic head, and the major vessels. So the widest, the safe window would be between SMA and the SMV. So we need fat traversing technique to avoid bowel loop puncture. And when the needle tip is near the mesenteric root, the patient may feel pain, and we can inject some lidocaine to stop the pain. Here is the real story. We advanced the needle beside the bowel loops, identify the window between SMA and SMV, made the biopsy, and afterward, pathology showed adenocarcinoma. This is case number 3, another case with pancreatic lesion at enzyme process. The lesion showed intermediate signal intensity on T2 weighted image and high signal intensity on diffusion weighted image. We found a safe pace between liver, kidney, duodenum, and the renal vein. This pace should run a little caudal-cranial, like what shown on the coronal images. Here is the real story. The needle tip could run on the pace between liver and the kidney easily. And to avoid duodenum puncture, we changed the needle tip direction twice. And the biopsy was made. And the pathology also showed adenocarcinoma. This slide shows the efficacy of CT-guided pancreas biopsy in our hospital as first-line diagnostic approach. It was in the era before US guide biopsy come up. And with the fat traversing technique, the sensitivity, specificity, and accuracy are high. And even for the small lesions, less than 20 millimeters lesion, the accuracy is still up to 91.1%. And in all 409 cases, the overall complication rate is 8.6%. And no life-threatening major complications and tumor seeding through the biopsy tract. So I think this technique is very effective. After biopsy, let's think about the drainage. Let's look back at the case number 2. The pelvic abscess surrounded by bones, major vessels, and edematous bowel loops. No straightforward path and a clear fat plan can be identified on the images. But when we think about anatomy by sagittal view, the caudal cranial approach would be safe for this case. So this is our drainage plan. This is the real story. We advance the needle a little caudal cranially. The angle is about 12 degrees. Because the needle tip will pass beside the bowel loop very closely, so we advance the needle slowly. And the feedback from the needle is very important. The feedback should be no resistance. If resistance occurs, we will stop advancing and make a scan to clarify where the needle tip is. And the feedback from patient is also very important. If acute pain or discomfort occurs, it is thought the needle tip is too close to a bowel loop. After a couple of tries, we puncture the abscess smoothly, and the drainage tube was smoothly inserted. The patient recovered well after days. This is another case needed CT-guided drainage. The liver abscess at segment 1. We don't want to insert a drainage tube through the healthy liver from here or from here. And now I think you have guessed it, which path we preferred. We prefer the path between between stomach and the left hepatic lobe. It is caudal cranially again. And the procedure is smoothly done, and patient told free of the pain and discomfort. Here is the post-drainage image. And subphrenic abscess is challenging for interventional radiologists. Right or left subphrenic abscess could be intervened by liver, stomach, or spleen. This is a right subphrenic abscess. The clinician asked to drain this abscess because the lesion showed poor response to antibiotics. And we don't want to puncture through the liver, spleen, or stomach. And what most we don't want is transthoracic puncture. A transthoracic route could bring the infectious material into thoracic cage. And we know the parietal pleura is usually much lower than the lung base. So the caudocranial angle would be large. And how can we know the caudocranial angle for each case? When we decide the skin puncture site, we can know the lesion depth on actual images. That's the distance A. And by the serial image, the actual cut, we can know the lesion, the distance B, the lesion from the skin puncture site. Then we do the mathematics, tangent function. Then we can know how much the caudocranial angle should be. So this is the real story of this case. The skin puncture site is here, and the caudocranial angle is more than 50 degrees. And the drainage tube was inserted smoothly. And the most important is it was not a transthoracic route. So here is the take-home message. CT-guided interventions are safe and effective. Fat traversing technique is good for central abdominal lesions. Caudocranial paste for subphrenic lesions can avoid transthoracic puncture, and during procedures, feedbacks from needles and the patients are both important. Thank you for listening.